Good morning, everyone. Welcome to another session of EMI Live. EMI Live is one of our Clinic Endocrinology and Medicine department's initiative to spread education to outside endocrinologists. This session will be recorded and put on our YouTube channel, so don't forget to check it out. Before we start and introduce our renowned speaker, I'd like to make a very special announcement. I would like to congratulate Dr. Michelle Lundholm. Dr. Lundholm won the first and the third place award in our Patient Safety Day for the Cleveland Clinic. Congratulations to Dr. Lundholm, who's our clinical fellow, along with the rest of the team, our endocrinology nurses, Dr. Rao, and everybody else who worked on these projects. All right. So it is my great pleasure to introduce Dr. Armstrong. Dr. Armstrong is professor of surgery with tenure at the University of Southern California. He holds a Master of Science in Tissue Repair and Wound Healing from the University of Wales and a PhD from University of Manchester, where he's also visiting professor. He's founder and co-director of the Southwestern Academic Limb Salvage Alliance and is director of USC's National Science Foundation, funded Center to Stream Healthcare in Place. He's one of the first 6 international wound care ambassadors and won the inaugural Georgetown Distinguished Award for Diabetic Limb Salvage. And I think I can spend a whole hour talking about his introduction, but he's also the past chair of scientific sessions for the ADA's Foot Care Council, past member of the National Board of Directors for the ADA, sits on the IDSA's Diabetic Foot Infection Advisory Committee. I need to talk to you afterwards. How do you find time for all of this? But we are going to start our talk today. Dr. Armstrong.
Well, thank you for that intro. You can only be disappointed after that, so buckle up, virtually or actually, for the disappointment. And by the way, we have a cozy crew, and so if you have any questions, please just stop me here, or even, and then maybe we'll. And typically, I'm sure you'll just take questions virtually later, which is perfectly fine. And thank you, Vinny, for your wonderful hospitality, and as well to our chair for this as well, for letting me play hooky from a crazy clinical service, as I said. Well, we give away all of our slides. If you guys, we just ask you to copy them, make them better, and pay it forward. So you can ping me later if you want any of these. I have all kinds of usual kind of Zoom-like features that aren't showing up on this one, but that doesn't matter. You guys can have any of these, and you're very, very welcome just to tweet at me. It's unfortunate that we don't have time enough to talk about the Center to Stream Healthcare in Place. I think there's probably a lot of collaborative work we can be doing around CCF internationally with a lot of that, maybe on our next visit virtually or actually. But what we're going to be talking about today is to try to cover the length and breadth of something that you probably largely ignore, that is the foot at the end of the body. And hopefully maybe after this, you'll start to care about it maybe just a little bit more than you do now, even though you have a lot of other things to care about. It's generally 11th, probably on your 10 most important things. Maybe after this, it'll be 9th. How does that sound? That's my goal for our chat today. And we're not going to talk about tissue repair and wound healing, although I may just touch on it a bit. There's so much going on in that area. What we're going to talk about is rather what happens in between, which is the foot, if you will, in remission, and how we can use kind of a team and technology and maybe a little tenacity to extend kind of ulcer-free days. So, ladies and gentlemen, this is what I do. I'm a toe doctor, as it were, a foot mechanic, and I work at the end of the body. And when you do this, you know, I can maybe think of a couple of gifts for working at the end of the body. One is that when you're out there, I can't think of anything this era of hubris that's more of an expression of humility than working on the foot. You know, especially in a surgical field, there's a lot of testosterone and hubris and chest thumping, but nothing makes you more humble than getting down there and looking after someone's foot. It transcends borders and time and religions and just about everything. So you sort of start there. And then the other great thing out there is that because you're on this anatomic peninsula, if you will, looking after the foot on the leg, it kind of forces you to collaborate with the rest of the anatomic mainland. And our team are working on everything from spray on skin and and spread on skin to wearable robots and gene therapy. So it really does force you to collaborate with the rest of the body and teams, and we are relentlessly so, and it makes it really a lot of fun. Those two great gifts, but unfortunately, there's a lot of bad going on right now, and in terms of this perspective, and this is the first. Starting with the bad, this is actually taking us back 120 something years ago. This is the first surgery ever caught on video. And you see Professor von Bergman, not here in Cleveland, but rather in Berlin, doing the first, or during an amputation, the first one ever caught on video. And you see, this looks like maybe the fellow. He doesn't know, where do I belong? Am I an attending? Am I a resident? Who am I? That is definitely the QA nurse. She's upset that he's not wearing gloves. I guess didn't get the message from Lister, but is happy that he turned the room over so fast. But the learning point here is not what's going on this video clip. It's what's happening maybe to our right here, and it's this woman or this man having her or his leg off maybe 120 years ago, probably had a better outlook on life than someone right now in Cleveland or in the U.S. or anywhere around the world that's listening in, and in terms of quality, years ahead of her or him. And I think that stinks. I think there's a lot we can do as a family to affect change in this area. And the good news is a lot of stuff is happening. But before we talk about some of the good, which we will kind of at the toward the end of this, there's a lot of bad. And I don't need to tell this group that foot complications it's kind of alliterative. They're common, complicated, and costly. But let's sort of get into this. If we look overall at the overall kind of these bubbles of demography across the United States, you all know the prevalence of diabetes and these numbers that keep increasing in many parts of the world. But if we look at these other things that we see, like peripheral artery disease and neuropathy, there are probably half of the patients now in the EU or within the United States, and a growing number in the rest of the world are developing loss of protective sensation or neuropathy and peripheral artery disease. And there's probably, give or take, maybe 1.5 million people living with a foot ulcer, and then plus severe peripheral artery disease, also known as CLTI, or chronic limb-threatening ischemia, or just limb loss. So these are the numbers just in the United States alone. But if you could probably take the overall gestalt here, if we want to use a little German in our morning, and spread this out around the world. And if we look at these data, we actually didn't believe these when we first looked at them. But if you, we looked at the World Health Organization's global burden of disease, and if you disaggregate, because who doesn't, like to disaggregate things, the foot and the lower extremity from the rest of diabetes, remarkably, by itself, it is its own top 10 condition. It's crazy. And this number seems to be increasing, not decreasing. And we see these other problems that we know are significant burdens on our patients in terms of years lived with disability. But there it is, the humble foot out at the end of the body. And if we also look at these data around the world, in every country, over the last generation, now you see sort of more of a thin kind of histogram and more of a portly one. And what we see here is an increase in all of these lower extremity complications of diabetes around the world. So this is what we're sort of faced with, and a sort of tsunami of demography. But even for places where we're seeing good things happening, like maybe there's a leveling off of amputation in some parts of the world. These data were from our friends Amadou and coworkers from France that showed maybe in the last decade there may have been a bit of leveling off of amputations in France that may be increasing now. But let's just take it for as gospel that they were leveling off in that decade. We see in that country increases in the rate of diabetic foot ulcers. So it's almost like maybe, I don't know, a generation ago where we saw reductions in cancer deaths, but more cancer. So sort of the denominator keeps increasing. These wounds keep coming at us, and it seems to be accelerating, not decelerating. And just by itself, having a wound appears to be associated with a greater risk for mortality that year. So about 2.5, the most conservative numbers suggested about 2.5-fold greater risk that year of dying in terms of all cause with a diabetic foot ulcer than if you don't have it. So, and then let's continue with the cavalcade of complexity. And if we look here, these foot ulcerations are certainly complex. We looked at every hospital, or excuse me, every outpatient visit over a 5-year period a few years ago. And what we saw was that foot ulcers and foot infections here on the left of this histogram, I think we can safely say in terms of risk for hospital admission and number of visits a year and complexity, these are at least as complicated as these other things that we know are important to us collectively as clinicians, whether it be renal disease, whether it be CAD or COPD, or any of the acronyms that are associated with bad outcomes in our patients. So common, complicated, and so what are some other ways to sort of look at this? If we just look at kind of how we describe it, if we wanted to try to describe this problem to maybe someone that doesn't think much about this all the time, maybe you could do it this way, because maybe now every second someone with diabetes around the world develops a diabetic foot ulcer. About half of those get infected. About 20% of those infections end up in hospital, which is why now there's an amputation, give or take, every 20 seconds. And the clock seems to be ticking in the wrong direction here, not in the right direction, although there are pockets of a lot of good. And tomorrow we're going to talk about today about a lot of good here. And tomorrow we'll have a talk to the Medicine Institute. We'll talk about some of the good there when we start putting teams together, some of which actually are happening here in Cleveland too. But we think for amputations that time's up. I mean, I think there's a lot we can do as a family to make a difference here, but a lot of these things are just intolerable, frankly, for our patients collectively. Let's continue just very briefly with some of the bad before we get to the good here in the latter part of the talk. But it's not fair to compare one terrible thing to another. But the fact of the matter is there's not very many people on the Zoom call care very much about feet. I don't know why you would, but probably everyone here thinks about diabetes, but not everyone outside these rooms or outside these virtual rooms thinks about diabetes, but everyone thinks about cancer. We've all had family members that have survived or have succumbed or are living with cancer. And people think about this a lot more than they do about those other two words on the left. So just as an academic exercise, let's compare these things, even though it's not fair to compare one terrible thing to another. If we just look at cost, and I kept these data in because they're already a decade, I can't believe they're a decade old, but these are the most conservative numbers, not the most aggressive numbers. If we look at this, what we see now is that this diabetic lower extremity complications are more expensive now than the 5 most expensive cancers in North America. That includes United States, Health Canada, and also within the National Health Service in England, et cetera, et cetera. And if that's, so this is the dollar per dollar cost, but look at this. If we just look at mortality rate, what we see here, looking at all cancers, about 37% in a 5-year mortality to give you kind of a baseline. But if you look here and you compare these other things that are terrible that we all know about and we all care about, we would never think of withholding therapy on someone with breast cancer or someone with lung cancer or pancreatic cancer, but it happens all the time in people with diabetes and diabetic foot problems. People say, oh, that patient, Ms. Garcia, she has that wound. Why don't you just cut her leg off and be done with it? You won't have to think about it as much. Well, for some patients, that's probably okay. It's probably the best therapy. But I think the data are going to show, both today and in the talk that we're going to do tomorrow, the data, I think that number is vanishingly small, which is a good thing because it tells us we have an opportunity to really affect change. And if continuing on this kind of comparison with cancer, if we compare just the health-related quality of life for diabetic foot ulcers, that's equivalent now to a recurrent breast cancer, just to give you an idea about how this affects health-related quality of life, even though we've looked at quality years ahead before. So I was just talking to my longtime friend and kind of big brother, Andrew Bolton, who's I think still the president of the American or the International Diabetes Federation, although he's sort of almost American, even though he's quite British. and sickle bus. We had this study not too long ago in a New England Journal where we looked not only at the diabetic foot ulcers, but at their recurrence. And let's, in using cancer as this backdrop, let's sort of look at this now. And if we see about diabetes, how does a person with diabetes get a foot ulcer? I don't need to review this with you, but it bears repeating how this sort of happens. People get a kind of a polyneuropathy. They develop a motor neuropathy, and that causes some wasting in the foot. So those small muscles in the foot atrophy, and the big muscles of the leg cause deformity. And you get essentially, I don't know the medical word for a jacked up, but you get a kind of a jacked up, is that a word? Foot, it may be in Cleveland. And so there's that. And then one has sensory neuropathy, of course, and that does kind of a stocking and glove distribution. You'll probably remember from your training. And then that allows a permissive environment for those deformities to lead by repetitive stress towards someone developing a callus and then ultimately an ulcer. You can also get autonomic neuropathy, not just systemically. God bless you. That was nice. You couldn't hear that virtually, but just let it out, is what I say. By the way, do you trust people just with a little one? Just with like with those little sneezes? You wonder what's behind their eyes. It's like people with an excessively clean desk. No one online knows what we're talking about. That's where you got to come live. So anyway, autonomic neuropathy. And so people get autonomic neuropathy and they get some decreased sweating. And so the skin becomes, let's use a culinary analogy, it becomes a little more like a cracker, viscoelastically, and a little less like a tortilla, if you will. That's not a good analogy this early in the morning, but forgive me. But all of that together develops, it leads to calluses, which lead to a hemorrhage and ultimately a foot ulcer, and then that can lead to infection and ultimately a higher risk for amputation in this population. But there are many ways that we have to collectively heal these wounds. We don't have time to talk about that today, but the good news is that between good quality debridement, offloading, and myriad now modalities to help epithelialize these wounds, many of these wounds can be healed over the 12 to 20 weeks, even though that's very difficult. I'm sort of not doing that part service. But I think more important than that is something that we largely ignore, which is this graph. What happens after they're healed? And should we really be so hubristic to think that we can heal anyone? And when we're dealing with a chronic disease, this is what I would offer you, because at 1 year, 40% of these folks are going to have another ulcer, 40, with the best available data we have from our group and from others. It's about 2/3 at 3 years and give or take 3/4 at 5. So recurrence in this population, ladies and gentlemen, is not only common, it's darn near likely. So if the foot in diabetes is a little bit like cancer, then maybe we ought to flip the script in how we describe this and how we discuss this with patients. You know, we don't have these discussions with our patients with diabetes like we do with cancer about the increased risk for mortality, about the increased risk for recurrence. And maybe, and because it's difficult, it's hard for us. It's a toll on us to do this constantly, but I think it can be really important because then wound healing, if the diabetic was a little like cancer, then wound healing would maybe be a little bit like remission. And when you use this word, this may just seem like a word. It's just sometimes words matter, sometimes they don't. But in this case, I would offer they do, because when you use this term and when you use the C word with your patients and you say, Mr. Jones, Ms. Smith, thank God you're healed, but we had this discussion already. This problem is a lot like cancer. And you use the cancer word and you see Ms. Jones stiffen up and Mr. Jones in the corner stiffen up, look up from his phone. And you say, look, the chances of you getting another wound and your long life with us is darn near 100%. But here's what's going to happen. We have all these things that we can do now with you in remission. Our goal is to make that wound as uncommon, as uncomplicated as possible, and to keep you out of the hospital. And we're going to have you back frequently here to see your foot doctor. If needed, we'll have you go see your vascular doctor to improve the blood flow. If we have to operate on you to change the way your foot hits the ground, we'll do that. And the same thing vascularly, but we'd rather not do that if we get you in the right shoes and have you back for your follow-up and keep you euglycemic. And you see things now, and you see her she was initially really stiff, and she gets a little bit less so because she's starting to think that there are now things that she can do to try to affect change in this. And she understands now that this problem now can't be checked off her list as maybe she would have if you used the word healing. But now maybe with a little more humility, this problem is not 11th like we talked about. Maybe it's just 9th on her list of important things to think about. You just keep bringing this problem up. Anyway, I'm sorry to spend time on this, but it's important because no one ever does. Our goal really, I think as clinicians now, especially with non-communicable diseases like diabetes, which is largely ignored, is to prevent and to mitigate, I shouldn't even use the word prevent, is to mitigate acute on chronic complications. I mean, that's it, is to do that. And if we could do that in almost any of these diseases, not just cancer, but cardiovascular disease and diabetes, then I think we can really affect change. Because look, I mean, even people in remission now, patients that have just healed, they're really, the risk for them is really for death, is even if they're being well cared for, not just the amputation. And so we really have to look at best medical therapy in this patient population and really go at them, not just ignore them, and not just think, oh, well, they'll come back if they have a problem, because they're going to get a problem. That's a certainty. It's absolutely positively. And so this is really probably a better way to look at it. Well, I'll tell you though, that's all the bad. Now we're going to talk about a little more good now, because look at this. This is really great. You're starting to see now entire health ministries coming up with solutions here based on the data that I just showed you, because you can now have, and these are from friends of ours, Graham Lease and others in the NHS Scotland, and this is spread across the UK in general. We've readopted it in parts of the United States now in California. But what you're seeing here now is kind of a green, yellow, red light, but you have a whole kind of concept of a remission clinic. We've just started a remission clinic at our LA County USC Medical Center, probably the first one in a county hospital in the United States. But you can apply more resources to these things to be able to get people in more frequently, just like you would for some of these other ones where there might be lower resources needed. And then kind of an active clinic where you have people with active tissue loss, active peripheral artery disease, and maybe active infection, where the goal is to try to get them back down into remission. Anyway, I don't want to show another one of these histograms this early in the morning here in Cleveland. That would be cruel and unusual, but these are just the things that are associated with recurrence. Let me just show you these three things. It's just we've already talked about this, neuropathy and peripheral artery disease, but what's this? A pre-ulcerative lesion. And a pre-ulcerative lesion is just a simple callus. And I just show this because, we ignore these things, but this is like, how do you describe this to a patient? Well, if you're looking at this clinically by Zoom, what you'll see is it looks to me like maybe one piggy here has gone to market there with the, yeah, I just did that to make myself crack up. But unless there's like a wicked hammer toe there, but you see that ulcer here, and this is really even worse because it's like bleeding into callus. So this is like a coming event that casts its shadow before. So if the foot in diabetes is a little like cancer, then maybe a callus is kind of like a breast lump, and maybe that's the way to describe it to another clinician, or even better to the patient or the family member, so they can look for this kind of thing, just to come in, because under there, almost for sure, is a diabetic foot ulcer that you can try to uncover with something like this. Anyway, so that was talking about a lot of bad stuff, but now let's talk about some of the stuff that we're doing and some other teams are doing around the country, around the world, to try to kind of mitigate severe recurrence. If we can't prevent everything from recurring, and maybe we can be a little more humble and we can kind of mitigate the more severe kinds of recurrences in remission. And maybe there's ways to do this in a kind of a logical way, and one that maybe can, to overuse the word scale up around the world. So if we're talking about developing a wound, there's really kind of an equation that has two real variables in the face of neuropathy, you can modulate two things. You can modulate pressure. You can change pressure by getting people into good shoes externally, or insoles, or casting, or orthoses. You could do it internally through surgery, or through physical therapy, or if you're British, physiotherapy. So that's one way to modulate pressure. The other thing there are two different ways to modulate pressure. And the other thing we can modulate is activity. And in the past, we really haven't been able to measure activity very well. We've been doing this for the last 20, 25 years, but it's been very expensive. Now that's gotten a lot cheaper to be able to do this and dose activity like we dose a drug. But what we see here, it's really, what we know is that these things are really, it's an imbalance of pressure and activity. And our goal is to try to bring that imbalance back into balance, so that what causes this is this imbalance. Bringing it back into balance is kind of the order of the day for maybe a foot specialist or a kind of a lower extremity specialist, both surgically, medically, mechanically. So this is one of my oldest slides. I think I made this when I was a student, like in the 80s and 90s. There should be like a sepia tone. It should be all cracked on the sides here. But I thought back then that maybe if we can only measure activity, then maybe, like with activity, it could be just like dosing. If you're an infectious disease doc, you have a peak and you have a trough. Too high and you have toxicity. Too low, you don't get the benefit, in that case, of maybe an antimicrobial. But the same thing with activity. Too high in a person with diabetes, and they're going to develop a wound, right? They're going to wear a hole in their foot. Too low, and they won't get the cardio-metabolic benefit or the feel-good benefit or just the functional benefit of being able to move through the world. But maybe if we can measure this, we can manage it, even by making the skin stronger, or by changing the way the foot hits the ground. That's kind of the overarching goal by this kind of graphic. And the cool thing now is that this may be able to happen. And this is from Lieberman's lab in Boston, but you see this guy running through the world here. And gosh, I wish I had patients like this. It's just great looking set of feet. I mean, if you're into that. But what you see is this is just the epitome of balance. It looks great. Our patients, in terms of their activity, are really not in this kind of balance, not just mechanically, but in terms of activity. These are data from already 20 years ago. I can't believe it. In the early days of what people now call wearables, we were giving them activity monitors that time-stamped their activity. Back then, these things cost a few $1,000s each, and our patients would lose about half of them. I think I spent about $1 million in one grant on these activity monitors that are now pretty much free. But what we saw there was pretty wild. It wasn't just the number of steps that they took, but it was really the variability in activity. Kind of like if you're looking at blood glucose, it'd be like like a swing in the value, but it was that variability that would predict the ulceration. So it would be like maybe a patient, like, I don't know, Ms. Garcia is sitting on the couch most of the time. And then all of a sudden she says, oh my goodness, I forgot my grandkid's birthday. And so she bounds off the couch, gets into her car, goes to the mall, and maybe takes twice as much activity in the span of a couple of hours as she usually does in a day. And then boom, Bob's your uncle, she comes home with a wound. That's what happens in this patient population. And if we can detect that, and we can maybe modulate and warn her, just like we would with a glucose meter in some ways. And so we've been using all kinds of different activity monitors over the years. This one is even weaved into a fabric of a shirt. And this is from many years ago. This is one of Bijan Najafi's, one of my old postdoc, if you will. And you see him running around, and this is like an ECG for your life. I mean, look at this. It's like a Holter monitor for your life. You can see someone running, jumping, prone, supine, begging for mercy, all those things that a postdoc will do. And we thought maybe we could start using this to dose activity like we would dose a drug and even out those peaks and troughs. And what's cool now, this is nothing more than an Excel spreadsheet. And we actually can plug stuff in there now. And after someone is healed, we can plug this in and we can give them suggested activity. And we can give this to them on their phone. and now even increasingly on their watch to try to ease them into their activity pattern, which is a lot of fun. I mean, so there's a lot going on in this area. So that's one thing that we can do now. That's almost free, just dose their activity. But here's another thing. I mean, everyone's really kind of into selfies, and it's all really solipsistic with the selfie business. But what if we could render this something that into something that might be helpful and useful in our clinics? And check this out. We do this thing called the foot selfie, and now we have a whole. And we actually have. This is one of my our medical students, Mark Swordlow. He just matched on Friday. He's going to be a plastic surgeon in Georgetown. What we can do now is we can just give our patients a simple little platform and their phone. And then even if they're blind, and this guy is blind actually, he was still able to identify a pre-ulcerative lesion, which it's hard to see here, but you can see that right in this area, a little bleeding, and right into this area. And just not a week goes by. We have foot selfie rounds every Monday, and not a week goes by where we don't stop a hospitalization just by going through like 100 or more of these things entirely manually. Now we also have a really cool program, thanks to my friend Moyhoon Yap in Manchester and Johnny Hancock's from NVIDIA. We have this thing called the Diabetic Foot Grand Challenge, where we're trying to teach a computer and AI to identify autonomously a wound in under 10 seconds. And that's something now that's happening. It's really exciting because it's really basic. But you can see, you can also monitor. And this is just a patient with a relatively large kind of 4-foot wound you see here. But he's even able now, with very limited joint mobility, to actually use something like this at home and in a consistent way, just monitoring these patients moving in to remission, which you see here being done. So like, as I said, there's a great deal of promise in this area. And the last few things that we'll talk about now, we'll talk a little bit about thermometry and then maybe about some smart socks. And then we're going to get into some implantable stuff. But check this out. So these are two of my mentors. You know, we should honor our mentors. And these are two. This is maybe the king of the diabetic foot, Professor Paul Brand, who used to treat people with leprosy in South Asia and India for many years. And if he's the king of all this stuff, this is the Crown Prince. This is Andrew Bolton back in the day. And that's me. I carry their bags. I don't carry his bags anymore. He passed away about 20 years ago. But this guy is he packs heavy. He's kind of high maintenance. But did I say that out loud? But Brand back in the day used to, in treating people with leprosy, these patients get a similar kind of neuropathy, and they can get the same kind of wounds that we see. So we've learned a lot from that. And what he said back then in using thermometry was that a wound will heat up before it breaks down. And that seems so simple, right? And it seems so obvious, so basic and obvious. But if you want to sound smart, and by the way, who doesn't want to sound smart? I'm trying and I'm failing here virtually and actually, but I think there's hope for you guys. When you guys are having your next break, just take a sip of whatever it is that you're drinking and just put it down and then say to your friend, inflammation, and walk away. And you'll be right. And they'll say, gosh, she's really smart. It doesn't really matter what you're talking about. Especially in chronic disease, just uncontrolled inflammation. By the way, the wheels are already off the wagon on this lecture. I'm just going to say that right now. Virtually everyone's already left. Okay. Oh, really? Whoever that person is, can you tell them that they have very low standards? Virtually, in my case. But anyway, so check this out. It's really great because this is true. You'll be able to identify. We can identify these asymmetries of inflammation, and we could do it relatively inexpensively. And we have been for quite a long time. And the data are kind of compelling in this area. And let me just show this to you. And we can actually use this kind of thing in clinic. And this is a more expensive thing, but even this isn't very expensive. This is only a couple of $100 through a little FLIR device from the guys in Santa Barbara. You could just hook it up to your iPhone or your Android. And this is a person with Charcot arthropathy, but you can just see here and just, scroll up and scroll down. You just see the difference. And we take this on rounds all the time too. But you don't have to use this. We just have our patients buy a simple thermometer on Amazon. Thanks to COVID, it's gone down in price even more. They're like $10 delivered now. It's crazy. and it's accurate enough. And you can sort of dose your activity by checking your skin temperature, just like you might dose your insulin by checking your glucose. I've thought for the last 30 years that this is like a glucose meter for the foot, and it really is. And it's starting to get used more and more now, thank goodness. And we're starting to see now, and oh, by the way, this is, and so Professor Brand was correct. Many years ago now already, we showed that this was true just a few weeks in advance, or a couple, this was, I think, just at 1 week, we saw an increase in temperature at the site of the pre-ulcerative area. So maybe now we can affect change. And we actually have guidelines that we give our patients. So once someone is healed, they're in remission. We start them. I showed you that little table earlier. We start them on this kind of activity regime. And we could do this by telehealth. We could do this even better in person, or a combination of these things to reinforce their activity. And in diabetology and endocrine, you understand this implicitly, I think culturally, but teaching other clinicians how to do this in a variety of medical and surgical disciplines is really, really important. And we have this focused on by our physical therapy group, who have just done a spectacular job at it. I'm just going to fly through some of these things now. How are we doing? Oh, we're good. Vinny, we're good. God dang. I thought that it was totally dull and boring. I thought I was just droning on, but we still have time. There's still time. There's not time to rescue this lecture. That's beyond rescue. Anyway, back to you. This is actually pretty cool. So this is if anything, foot-wise can be cool, which I think is a big question. But this is just a thermometer in a bath mat. And this study already a few years ago now showed that you can identify wounds not hours in advance. That would probably be okay. But you can actually even do it weeks in advance, which is crazy. I mean, that's really a long time. And so you can react. And of course, now with this kind of stuff, weeks in advance is horrendously oversensitive and not very specific. But as you get closer to the index event, it appears to get more and more specific. But we can be agnostic to these different tools, or at least these different companies, and we can be kind of, if you will, evangelical about the idea that this is only going to get better. And it really is. And so these different form factors, I think we're going to start to see some of these things. And I think you in diabetes care will likely start to see these data, just as you might be looking at all the glucose and cardiac tracings that you do now. And I think you're probably very, very comfortable in doing that kind of thing already. As you can start just adding dosing activity into your regime, along with your podiatric surgical colleagues as well. So let's move up the body. After bath mats, the next would be maybe socks. There's all kinds of really cool, intelligent textiles. These are already, actually, these are about 20 years old, but we started when we started publishing on them early. And the first pair of socks that these smart socks that we had with Bijan and I, these things cost $70,000 to make. I swear to God, it's a true story. I'm just thinking about this. We actually lost one, and I was making a joke like we lost one in the dryer. You know, like it just anyway. But I still have the original one in my drawer though. Anyway, these things are cool because you can use different solutions, a fiber optic or a pressure transducer, and you can measure thermometry, but you can also look at joint angle and all kinds of other things with these things. But probably the important thing is pressure and more important, temperature. And so there was a really clever biomedical engineer, Ran Ma, who came up to us at one of our diabetic foot meetings, DEF CON, a few years ago. And she said to us, she said, "Oh, Armstrong, I saw those socks that you were talking about, and they're ugly. But I read what you wrote about in the 90s about subscribing to your socks like you'd subscribe to your cable bill, and we think we could do better." And so she starts some company and with like 5 or 6 of your friends, which I guess is like a cool thing to do now. And so do I have it? I think I do. She ends up going to Rand starts this company, and then they end up going to the the Consumer Electronics Show in Vegas, and she's going up against like all of these things like virtual reality and augmented reality, and it ends up that reality ends up winning with this sort of just simple kind of subscription concept where you give people socks and they end up winning this prize. This is already 4 or 5 years ago, and so it's crazy that socks, foot stuff now is kind of getting geek-tastic, right? I mean, so you're starting to see these sort of things that were they used to be completely ignored are starting to get less ignored, which is kind of fun now. And we actually took we meaning both our team, not this team here, a couple of years later, took a smart boot idea there, and I have a NIH grant where we're making a smart boot as well to improve adherence for offloading. And we're getting a similar kind of reaction now. So anyway, let's kind of continue to move up the body. There are all kinds of really cool tools now available. This is from Zoltan Pataki. What a great name, Zoltan. Zoltan, believe it or not, is an endocrinologist, diabetologist in Geneva, or if you're a Francophile, Genève. But he actually developed a really cool idea about having a smart insole, and what if an insole could get out of its own way if it saw kind of a hot spot. And this is the idea here. This actually is a really cool concept from the guys and gals at EPFL. And it seems to be promising. And we think we can maybe make this into like a closed loop system, almost like an artificial pancreas for the foot, for an insole, where it could identify a hot spot, maybe get out of its own way ultimately. We'll see there. Because all these things, if you think about it, all the things that you're looking at in terms of alerts and we are looking at collectively are a little like kind of like just a fire alarm. But then if you have a fire alarm, in your house, this is like, right. So this is the equivalent of a fire alarm, just that thermometry. And then if we think about clinicians, I mean, we're like the fire department, right? And the ED or the doctor's office is like the fire department, but then we have to ask ourselves, what's the fire extinguisher in the home? And right now there's a massive unmet need, because the only thing we have right now to extinguish the fire if you have a pre-ulcerative lesion in a person in remission is just to tell the person to change their activity. Maybe we can have something that could improve the quality of the tissue, and maybe that could be done pharmacologically, maybe it could be done topically, or even mechanically. And it's an exciting time, because I think there may be some real breakthroughs in this area as well as we move forward. So the last couple of things I'm going to show you now, those were things associated with wounds. Now we'll talk about vascular disease and then close. But I told you that these wearables, they're really getting a little passé now, being around for so long, and we're also used to them. But what about now if we can marry these wearables with injectables? And so now this is a thing, and this is a tool from our friends at a company called Profusa, and Natalie Wisniewski has developed a tool that you can inject under the skin and then ping it with a laser, because lasers. And with your laser, you can identify all kinds of analytes, not just oxygenation, but even glucose now. But stay tuned on that. That's a whole different discussion. And one of my old residents, Miguel Montero Baker, did the first human study on this a few years ago now, but it actually seems to work. And you can do this from a distance. So you can imagine being able to detect this, having a whole series of sensors on and around you that could be detecting a lot of these different analytes. And like I said, in diabetology, I think you're right in the middle of a lot of these things now. It's a fun time to be working in this area, and for me too, as a toe doctor. But there you are. This is a fun time to be seeing this. And this is the last thing I'll show you. This has been around for a little while now, but the concept now is getting more and more popular. So this is a PTFE Gore-Tex conduit graft used obviously to bypass things, but and then look at here. This is like a little area where you can measure hemodynamics, because once someone has had a vascular intervention, one of my friends here, Lee Kirksey, is a world-class vascular surgeon, and his team here, and once he's done his bypass, that person's in vascular remission as well. It's only time before either the patient goes down or the repair goes down, What if you could detect that in advance rather than having the person into clinic constantly to get scanned? Well, check this out. So like I said, this is a Bluetooth LE tool, and you can actually pair with this on the back table in the operating room, just as you might pair with your headset, as you will. And now at home, now someone could be identifying and detecting turbulent flow that might predict a development of a diabetic, or I should say of turbulent flow, and maybe when that a graft was going to go down. And this kind of idea, looking at hemodynamics as well as tissue perfusion in that last slide, really is the way forward. And you can think about all these other tools that we have, and kind of the masters of the universe, the women and men working in this area, are going to have to be the ones that make all of this stuff start to communicate with one another. So, ladies and gentlemen, I'll conclude with this. See if I think I put this video in. When I travel a bit, and when I do, I will. Let me show you this video, because this was something I got from my friend when I was in South Africa, and this is actually, I think, East Africa. And so this is this made me crack up. So this is a giraffe in East Africa. I'm not a wildlife biologist. That looks like a Grant's gazelle, I believe, running really fast, not thinking, small cranium. Reminds me of me. Giraffe, gazelle, lion, relaxed, gray hair in the mane, kind of knows where to hang out, and boom. I don't even know what video is coming up next year. And so this guy and his buddy are going to have kind of some sort of mid-morning kind of brunch, East African brunch, at the expense of this gazelle. And when I first saw this, I just cracked up, because I said, man, that's me. It's like in clinic, right? I would be saying, don't just stand there, do something. Make her NPO, write that order, get him in a treatment chair. Well, so I then saw, I was immediately struck by a great quote from this guy. This is Charles Dodgson, also known as Lewis Carroll. And when he was at Oxford in Alice's Adventures in Wonderland, he kind of flipped the script, and he said this, don't just do something, stand there. And I think if we do that, and if we regard what we do, I think a lot of what we do is probably pretty good. But we could probably, if we challenge what we do, we could probably tweak and iterate. And that's why it's the practice of medicine, of surgery, of nursing. And hopefully we can make an effect change and make a difference in my little area, my little humble area, keep a few more legs on a few more bodies, and extend what I would call kind of the holy trinity, which would be ulcer-free days, hospital-free days, and activity-rich days for our patients. And ladies and gentlemen, thank you so much for putting up with me.
Thank you so much. I think this was a masterclass on how to give a talk. Oh, and I have to thank him, and I have to thank Cecilia for the information and the entertainment. I think people will be putting things in the chat. Yeah, go ahead.
Yeah. Yeah, by the way, I'll repeat this online. Yes. Yeah. Yeah. That's a great question. By the way, even if it wasn't a great question, I would say that's a great question. But that's a great question. I'll tell you the classification of questions in a minute, because I have there was an Armstrong classification that I used to tell my fellows. Okay. The question for those of you in your PJs online is we were talking about thermometry and what's sort of the timeline for when a wound will sort of heat up before it breaks down. So the data suggests that actually it's not just a few minutes or a few hours like I would think, right? It appears to be longer. It may be sometimes weeks in advance. But when that happens, the data are very noisy. As you get closer to the event, it looks like it gets the actual kind of persistence of a hot spot gets more persistent. But I don't want to make this too complicated, but it looks like it may even be more complicated than that when we add in as peripheral artery disease, because our patients are getting, now it used to be most of our patients were purely neuropathic, right? But now most of our patients in North America, in the EU, and now around the world, right? Even on the Arabian Peninsula now, probably 20–30% have peripheral artery disease, but now here, half of them do. So that may mitigate some of the timeline and kind of the magnitude of it, but it's still going to likely get more specific as you get closer to the event. The other thing is, it's really interesting because what we're seeing, and this is probably TMI, too much information for you, but here we go. What we're also finding is, it's fascinating, is that it's not just the number of steps and unprotected walking, but it may be unprotected standing. But, we used to say sitting is the new smoking, but standing could be dangerous for some of our patients because they don't have the gift of pain, right? And so when they're standing, they may be making, by not moving much when they're standing and being really rigid, they may create little mini ischemia reperfusion injuries in those areas. And we're trying to measure that too. And we think that we're seeing that, and we might see that with thermometry, but we might also see it with other things like some of these implantable sensors. We might also see it with hyperspectral imaging or some other tools. But it's fascinating nonetheless, because I think these can be applied all over the body. Great question. Yes, sir. By the way, if I were watching this lecture, now I don't know that I would be watching this lecture, but were I would be sitting back there too. Yes. Yeah. 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 That's another great question. And it is really a good question. So the question is, for those of you at home, what, after identifying a hotspot, what do you do for that patient? That's where I was showing you that question mark, and there was showed you kind of a fire extinguisher. What is it that we have to do right now? The tools that we have, I think the tools can help for sure. I mean, there are things like modifying shoes, right? So if an area is irritating, that area, maybe you, like you said, maybe you can make an accommodation for it in the shoe. If that's number one. Number two, if it's persistent and there's a deformity, maybe you can operate on the patient and change the way the foot hits the ground and take that area off and mitigate it. I was just doing that yesterday. And give people more steps essentially before they break down. The other thing you could possibly do, there may be topicals ultimately that might strengthen the quality of the skin or the epidermis and maybe give you more steps and maybe make it more kind of robust. There may also be other types of therapies that could do that as well. But those are kind of the internal and external therapies that we have. But I think that's an area that could be rife for innovation. We're also, not to make the short answer that I should have given you long, but there are other things that we're doing internally, which is, believe it or not, we're taking fat. I just did this last week. We take fat from the belly, and then we kind of contour the bottom of the foot, giving people a few more steps. It's almost like a little internal orthotic, if you will. As some of the PhD work I did like 20 years ago was in doing this, but with other kinds of tissue augmenting things. But you can use someone's own fat. So that may be something you could do as an adjunct. But I think there's a lot of other things that we can do that we're not doing because we're just not focusing on this as well as we could. But it's a fun time to be doing it because we're seeing the coming event and we're seeing the problem afterwards. That middle area, there could be a lot of innovation now. Great question.
So, diabetic patients will be delighted if you take fat off
That's what this is what all of our patients say. And so that is absolutely true. I think for our population. We used to say, well, we're giving them a surgery, but they all say, oh, I'll do it. And then the patient's parent, a significant other next door, they'll say, I'll give them my fat. Yes. Oh, yes. Yeah.
No, I really want to thank you for this great talk and very enlightening. I also want to apologize because, after taking an overnight trip to come to Cleveland, we welcomed you with an empty room. And I can guarantee you that all of our colleagues are, in their office and in the living rooms, enjoying this very great talk. So tomorrow you are giving a lecture here again, medical rounds, 7:30. I cannot guarantee you that our colleagues from Abu Dhabi or London who are listening will be here, but I can guarantee you that this room is going to be very well attended tomorrow because you really deserve a great audience. And as I said, everybody has been listening virtually. I have a question. And we used to examine our patients years ago, but right now I'm not sure that we do that anymore. So how are we doing? Which data do you have supporting how PCPs and endocrinologists we examine food or the feet of our patients, and how often should we do that to really avoid what you are showing us?
Yeah.
And I also, at the end, I would love you if you tell us what you're going to be talking about tomorrow, because I'm sure you're going to be talking about more treatment, maybe, and issues that would be also very interesting. Great. Thank you so much.
No, not at all. This was. Oh wait, you guys got to both come in here now. This is going to happen right now. Okay, here we go. Come on in, Vinny. Oh, Vinny, you got your stuff in here. Oh, here we go.
Great. I forgot to thank our fellows for being here in person.
Yeah, for sure. Well, so the answer is how often should you be checking the foot? So the answer is, here's the good news. If you want to lay hands on the feet, this is I think you can definitely do it because you'd be amazed how often you're going to find something. But the data suggests that depending on, I showed this green, yellow, and red light thing early on, and that actually shows some of the things about how to actually assess the foot and how often. But someone without neuropathy needs to get checked by his or her diabetes specialist and foot doctor, maybe annually, or at least a foot check annually. Although the data suggests it might not even have to be annually. But we like to do it annually because if you do it every 2 years, then they tend to slide out and they get lost. So we say annually for someone without neuropathy and without vascular disease. So that's the lowest risk. If you add some of the other complications, like any neuropathy or certainly any vascular disease, those people need to get checked by their foot doctor at least a couple of times a year, 2 or 3 times a year. If they start developing deformity a little more often, if they've had an active problem and they're in remission, then that person needs to come back for their foot visit to their foot doctor at least. It might even be as much as every month. It's very frequent, but sometimes it's every other month or every third month, depending on the level of their deformity, just to come in for some basic stuff, even if it would be for their foot doctor, just to get their nails checked and their calluses trimmed. It's amazing how effective that is. If they do that, if they just see their foot doctor and a member of the diabetes team, their relative risk for an amputation goes down anywhere from on the low end around just 19% in 5-6 years to the high end. And I know this sounds crazy, more than 80%. Yeah, it's an amazing number. I mean, if you had a 5% risk reduction, you have a blockbuster drug, but it can be 80. I'll show those data tomorrow now that we mentioned it. But so that kind of combination between medicine and podiatry can be really, really helpful. The things to look for are the things, are really just things that were different. I mean, we tell the patient to look for something different, but I talked about a callus, I talked about deformity, I talked about neuropathy, and all of these things can be measured without any power. We created this comprehensive diabetic foot exam back in the mid 2000s, And this is now part of the World Health Organization and our International Diabetes Federation's kind of and our working groups guidelines, and all of this can be done pretty quickly. We have it boiled down to you can do this in 3 minutes, and that's been validated. But if you don't have 3 minutes, I mean, really, because I think a lot of places people don't, you can do it in 1 minute with some stuff. So with some key things, just like I mentioned. Great question. Oh, and by the way, for tomorrow, I forgot to tell you, for tomorrow, I guess what I'll talk about, I can modify it too. What the heck? I mean, maybe I'll start like this, talking about the scope of the problem, but then I'll, for everyone, just a level set, as they say. I hate that term, level set, and I just said it. I've become what I hate. This is so sad. And then I'll talk about putting teams together here and around the world, and the ability to do that and to make a difference. That's what I'll talk about. Look at this. Well, you're starting it. Yeah, well, there you go. You're starting at the end of the body and you're working your way approximately. Yeah.
So one question is, how much does insurance cover?
Yeah.
And second, as the clinic is expanding into the regional facilities and everything,
yeah,
we saw a lot of patients in, like, I won't say rural areas, but underserved areas.
Yeah.
Who are not compliant with like the basic diabetes
right
in spite of such great drugs.
Yeah.
How do you get them to be compliant with foot care?
Yeah.
Some of them I feel like end up in even our clinics when the feet is an issue because now they're worried about it.
Yeah. So this is a great question, and the answer is that trying to get these patients, how do you get someone to do what you think they should be doing and what they already think that they should be doing, right? I mean, this is like it's so easy to talk about on a Zoom or in a chat like this, and it's hard to do in real life. But the short answer to all of this, I have two vascular surgeons that have NIH K Career Development Awards, and believe it or not, these are surgeons, right? These are vascular surgeons. Who would not be known to be doing, population-based stuff, right? You'd think that they'd be doing very specific stuff like this. In fact, one of them is not too far from here, Samantha Mintz in West Virginia, and she is doing really amazing work looking at the difference between rurality and an urban environment and outreach to these very patients, to these high-risk patients, even some of the lower risk patients, and how you can meet them where they are, as it were. Another one is Ziwei Tan, and Ziwei is one of my partners, and he's has a K award with me, and so he's doing the same thing. And believe it or not, he was with us when I was in Arizona, looking at like 22 different Native American nations. Now he's in Los Angeles County, looking at 10.1 million people, and the zip code kind of it's a zip code lottery. It's a 10-fold difference in amputation rate, depending on what your zip code is in this broad area around Los Angeles County. And he's looking at how to get to some of these patients like you would get to them in the middle of a desert. And what we're finding is that spending money, not just on the specialist, on the endocrinologist, on the vascular surgeon, on the podiatric surgeon, but on a sort of navigators and people that can actually be continuously sort of bugging these people and communicating with them may be a great way forward. And doing this in the home has real promise. I'll tell you one other quick thing that's just happened. So after COVID, I guess I'm the first person to be here live after COVID, but one of the good things after COVID was there's a program in our Los Angeles County now that was started by a friend of mine, Chris Lynch, who's an infectious disease doc, called Safer at Home. And Brad Spellberg, who's our CMO there, and Chris started this mostly ostensibly for COVID. Now, the most common thing that's being treated there are people with diabetes and diabetic foot problems. So these patients are all being treated at home with very complex therapy for COVID, for diabetic foot complications, for CHF, for other sorts of things. And these are folks that wouldn't normally have even money to pay for, they'd have to ration food to pay for their bus fare. And this has been, I'm not going to use the word game changer, but it's been a game changer for them. And we're really highlighting this. And we put the foot selfie program that I showed you into that safer at home thing. And a lot of this stuff now is being handled by through us by teams. And actually, I have a whole teams kind of chat going on, a HIPAA compliant teams thing with these safer at home patients. And at any given time, there's probably 40 patients, 40 or 50 that are being treated like this. And of those, about 30 have diabetes and lower extremity problems. The rest have, maybe a pilonidal cyst or maybe CHF or maybe has some other complication. It's amazing what's happening.
Well, this sounds like a great program for Madison. Something we have
See?
Looking into.
Yeah, yeah, buckle up. I'm happy to hook you up on this because it's really, this is real. I mean, it's not people, sometimes it's vaporware, someone talking from the podium and coming from a long way off. This is happening now.
What we have seen with technology is people like the phone. They don't like the computer.
Correct.
They want to get into Zoom.
Yeah.
But everybody knows how to click a button.
Yeah, that's right. That's why this seems to work. And you just got to make it, like if you're ordering a cab, who does that anymore, right? Uber. It's they call it frictionless, right? And if you can make it frictionless for the patient, that's better. And some people just want to call that they may not even want to take a picture, and you just meet them where they are. So yeah, but a phone, just using the phone and sending a photo speaks volumes.
One last question, very basic. I get this often.
You're a glutton for toe punishment.
Patients all ask, what are the best shoes? So what do you recommend?
Yeah, I think there are, it's just not the right answer here. It really just depends on the patient, right? The best shoes are the shoes that the person wants to wear, right? And that will meet to certain basic elements of protection. And so it has to have ideally enough room in the kind of the toe box so that those toes aren't like, pushing out of the top of the shoe and too narrow. And the insole, has to have a certain amount of cushioning, but as their main shoe. And there are criteria that say what a therapeutic shoe is, but that's not really, those are ridiculous criteria that are not based in any reality, but it's based on billing. And there's really been a race to the bottom, in my opinion, in quality in shoes and insoles and things like that. This really super boring area, but it's an area that really needs to be disrupted because we need kind of a lens crafter's it's not a good model, but like a model where someone could go in and like get something that they want to wear that looks reasonable and good that they're going to go home with, and that doesn't happen well enough. But a good athletic shoe probably offloads about as well in the lab without any modifications as an unmodified prescriptive shoe. And then when you start modifying both of them, you could start really tweaking certain areas. The trouble is that when you modify them, it costs the company that's modifying them money that maybe they can't afford by what Medicare is paying for them. So the patient has to pay, and many of the patients are not going to pay for it, even though they would pay maybe $100 or $200 for a pair of shoes normally. But in this case, they're not going to do it. So I think there just has to be a different, and if they don't have enough money to do it, there's just nothing that can be done. And it's a lot of this can be sorted out if someone doesn't have insurance. A lot of things can be covered, and if they have good insurance, a lot of this stuff can be covered. But it's that massive middle of sort of underinsured patients. And these patients are being hurt by, and that's just one thing with these shoes, but there are patients being really hurt by being underinsured. And I think there are answers there too, right? There are really good, like federally qualified FQHCs, federally qualified health centers. I don't know how many exist in and around Cleveland, but there are 2,000 FQHCs now. I'm learning all about these because we're using them to identify patients that could benefit from some of the studies we're doing with our NIH, 2,000 in California, and they're designed to address some of this stuff and keep people out of the emergency department But yeah, the middle underinsured group is really rough. But to be continued.
No, it's interesting. We get these avalanche of forms that come in.
Oh, that's the other thing. Yeah.
Patients don't wear them.
Yeah. Right. And then they just end up sitting next to the like a doorstop, right, or something, right? But that's so I would rather someone have something that doesn't work, and maybe them get a wound every now and then, not a severe one, but then not have anything at all, right? Because we can work with that. We can work with almost anything, but we just have to have those guys and gals that make these things just have to have enough money to be able to modify them. Because right now what they do is the worst possible thing. They just like slap just an insole in the things, and you might as well just go to to the sporting goods store and you'll get a better pair if it's not unmodified. There you want, correct. Well, New Balance does, right? That's a possibility. All these different ones do, Brooks, New Balance. But one of the other things that we need to do as well is, and this is happening as well, as some of these sensors get less expensive, we can be, I think we need to allow these people to get paid and paid well if they do a certain job of offloading the foot and protecting it. Because right now, there's no you're not measuring what you manage, except what we do in our lab and in some of our studies.
This is great technology, and I hope we see it in real time.
Yeah. Well, the good news is that for some of these insurance companies that are on the hook for some of this stuff for the first time in my little career, they're starting to call us rather than vice versa. So I don't want to say anything because but it's cool now that you're starting to talk to. It's sort of the roles are getting reversed. So to be continued.